Welcome to another episode in our independent medical education video series about astigmatism management during cataract surgery. I'm Dr. Dmitriew.
And I'm Dr. Farid. Last time we talked about options that cataract surgeons have to take preoperative astigmatism management to the next level. This time we'll be talking more about intraoperative alignment and treatment options for managing residual astigmatism postoperatively. And while we're at it, we're also going to talk about what are some of the barriers to further toric adoption and managing astigmatism. So, Andy, my question to you is, in the perioperative setting, how are you marking your patients? How are you planning for where you're going to place the toric lens?
So my number one choice is digital marking. And I would still say that the reason for that is the workflow, number one, and second, precision. So by combining these two features, we're actually improving our postoperative outcomes. And by that, we're improving the quality of life of the patient.
So what I do is usually in the preoperative setting, I have the patient sit up. Usually my resident goes in there and does a manual marking. We have some nice additional digital technology that we can use intraoperatively to help us with further alignment. But I think at a minimum, you have to do a digital or manual marking in the preoperative setting. But if you can move to digital, which system are you using?
I'm using Varian, and I started using Varian many years ago, almost 10 years ago. We see that the improved software plus improved hardware give us really confidence in the final outcomes. Yeah. But I guess you have the same feelings in your
I do. I actually use Callisto, but it's very similar. Essentially, it puts a light through my microscope at exactly the axis that I've inputted, and so it makes it very easy to just line it up with that digital mark. So digital markers are great, but at least manual marking is a bare minimum, I think.
Yes, and I think my environment is pretty mixed because even if my preference is digital marking, I'm still operating at the university where we're using manual marking as a primary choice. So obviously we're pretty confident in the systems we use, no matter if it's digital or manual. We have extremely good calculators, extremely good technology, but we end up in a small part of patients with postoperative residual astigmatism and surprises. What is your potential standards in your daily care to deal with that? How would you do that?
You do have a postoperative refractive surprise. I think I have a little sort of algorithm I go through. First of all, if the patient is 20 happy and they're not complaining, don't chase it, right? So that's number one, really, is assess how the patient feels. You don't have to chase every half a diopter of astigmatism, but some patients will be visually bothered with that residual astigmatism. So the thing you have to figure out is the toric lens not aligned properly. I think an issue with toric rotation is much less with current toric lenses. They don't rotate, they're very rotationally stable. I think if the toric is off, it's maybe because I didn't put it in the right place more often than a problem of rotation. Is that the problem, or are you off in terms of the degree of astigmatism? Did you undercorrect your astigmatism or overcorrect it? So, in a case where I might need to rotate the lens, for example, I do go in within the first, obviously you want to make sure there's refractive stability, but within the first 3 months, I like to go in, open the capsule, rotate. Sometimes I'll put a capsular tension ring in at that time, put the lens on the axis where I need it to be, and I'm done. And that surgery can be done in less than 10 minutes. Certainly if the degree of astigmatism is off, sometimes you don't need to go back into the eye. So if your toric power is maybe not strong enough, you can put relaxing incisions in that axis to give yourself further decline. So you can either do that with a femtosecond laser, or I also like to make manual LRIs at the slit lamp, which is an option as well. So sometimes you can correct it that way. Of course, doing LASIK or PRK will take care of both residual astigmatism and spherical, offset if needed. So if your sphere and your cylinder are off, you have the option of doing a LASIK or a PRK. So you have all of these tools, whether it's a IOL rotation, whether it's a LASIK or PRK, or manual or femtosecond laser limbal relaxing incisions. You sort of have to go through this algorithm in your mind and figure out which of those approaches is best.
There are many surgeons asking a question, what is the level of astigmatism they should correct? And I think it's one of the hardest questions to answer because that depends on the lens. What's your opinion on that?
I think it depends on the lens and it depends on the patient. So I was just telling this story of my brother-in-law whose surgery I did with a multifocal toric. He had a lot of astigmatism preoperatively. We got him way down. He had maybe 3/4 of a diopter left, but it was visually significant for him. He was happy, but I could make him happier. So we actually went to the femtosecond laser. I put in relaxing incisions after surgery, took care of that 0.75 diopters, and he's over the moon happy. So I think, depends on the patients and how much that residual cylinder is bothersome. But if you can treat it and take them back and go to that next level, you can really make a patient go from happy to very happy or ecstatic.
And I guess it's worth repeating at this point something what we mentioned during the first episodes. So the radical correction of against the rule astigmatism is something worth repeating again. I think you
absolutely, and it can shift over time too. We know that as patients age, they become more against the rule astigmatism. So I think overcorrecting is important, and having a lower threshold even after a few years to give them a little additional correction is something to consider. If you do have residual refractive error, don't abandon the patient. Figure it out, and the patient really at the end of the day appreciates that additional work you put into figuring out what's going on and being able to help them get to their goal. So my next question to you, Andy, is what do you think is limiting a lot of surgeons from adopting toric lenses and from treating astigmatism? It's such an important part of vision, and it degrades vision so much. Why are we not all aggressively treating astigmatism?
I would say that's one of the best and at the same time hardest questions in that astigmatism correction. So I would say, first of all, you need to believe that deterioration of visual quality is one of the most important parts of astigmatism presence. And if you see the simulation of vision of patients who have 0.5, 1 diopter, 1.5 diopter of astigmatism, you know that these patients cannot just live with that, right? So we need to push surgeons to understand it. So education is still one part. Second part, try to involve the surgeons in the use of modern methods, because sometimes for the experienced surgeon, it's much easier to use digital marking instead of using manual. It's obviously a personal choice, but I would say I know many people who said, digital marking was something I expected and made my work much easier.
Right. I completely agree with you. I think one of the issues is what we don't understand sometimes is that correcting astigmatism in spectacles is very different from correcting astigmatism in the eye as well. So the quality of vision is different. When you correct that aberration closer to the nodal point of the optical system, the quality of vision is better. So, you can't say, well, the patient's going to wear glasses afterwards and that'll be fine, because you're really depriving that patient of the optimal vision that they can have. And I think in this day and age, patients demand excellent vision, and we can deliver that. So it's really on us as surgeons to learn about the best technology, learn about best approaches to it, and offer it to our patients, because otherwise we're not doing the best for our patients.
And I think we were discussing patients with 0.5, 1 diopter of astigmatism, and there are still patients who are 3 or 4, or still have 3 or 4 diopters of astigmatism, and are not getting intraocular correction during cataract surgery, which means it's a potentially healthy eye with very good quality of vision. And you can correct 4 or 5 diopters of astigmatism in glasses. This patient will be undercorrected for the rest of his or her life, and the quality of vision suffers. So I guess that should be our target as the first choice. Please consider the correction of high values of astigmatism, and then go to lower values like 2 diopters, 1.5, or 1 whenever the reimbursement is possible. Just use the reimbursement. If not, consider the co-payment process or payment by the patient.
Absolutely.
So managing astigmatism can be tricky, and hopefully you've gotten some useful tips and tricks out of this independent medical education series on how to have a life-changing impact on patients' vision.
Understanding how astigmatism can affect measurements, getting to know the ins and outs of toric IOLs, and putting it all together in the operating room and your patient conversations will significantly improve your practice, and we hope these videos have helped you in your journey. Thanks so much.